Hi, everyone. Good afternoon or good morning for some of you. It's so wonderful to see you all. For those who don't know me, I'm a policy associate at NASHP on our behavioral population and public health team. I'm also joined by some of my lovely colleagues on our health and housing team, Sandra Wilkness, Elaine Sheehan, and Robin Wagner. I did just want to kick us off by saying, for those unfamiliar with NASHP, we're a nonprofit, nonpartisan organization dedicated to supporting state officials, and we've been working with states to support health and housing initiatives for about 7 years now. I just want to give a few quick comments before we kick off and hand off to our wonderful speakers. Okay, thank you. So if you wouldn't mind going to the third slide. Elaine, we just see your,
Are you seeing that?
I think
No.
maybe seeing a different window. We're just seeing the first slide. Sorry.
Sorry about that. Hold on one second.
For those who are just joining, welcome. We're just getting our slides up and gonna get started. So really excited today for our second open learning community meeting. As a reminder for people who haven't joined these meetings before, we're hosting these learning communities for all state officials to provide kind of a more foundational understanding of elements that are critical to align health and housing approaches in states. So today we're going to introduce some key housing partners that are really important for you all to be aware of and working with to strategically align resources in your state. So today we're having kind of a 101 level conversation, but we think that even those who are already in the weeds and implementing initiatives in their state will hopefully find this helpful for understanding the key resources that these partners bring and how you all should be thinking about partnering with them. And we're really excited. Our presenters today are all really seasoned and dedicated people with a really broad range of experiences. So we really hope that you'll maximize your time with them on the line. So to the next slide, please. Just a few quick housekeeping items before we get started. This is a state-only conversation, so please drop off if you are not with state government, and please feel free to reach out to our team with any questions or comments. And with that in mind, we are recording this really to get the rich information from the presentations, but we're not going to share out any of the discussion and Q&A pieces. And there are far too many people on the line to do introductions, but please do feel free to put your name and state agency in the chat so we know who's with us. And really throughout today's discussion, please use the chat freely to ask any questions, share challenges, share resources you think might be helpful to others. And we're going to pause after each presentation for any burning or clarifying questions. And after all the presentations, we'll open it up for further Q&A and discussion. So again, just really encourage you all to speak up and ask questions, share challenges. Truly no questions too basic. So without further ado, I'm going to introduce our speakers for today while Elaine transitions to the Andrea slides. And I'll let everyone kind of provide some additional introduction. But today we have with us Andrea Bell, who's the Executive Director of Oregon Housing and Community Services. And David Bridge, who's the Special Needs Program Administrator for the Arizona Department of Housing, and Dominic Mitchell, who's the Deputy Executive Director for the Minneapolis Public Housing Authority. So I think we'll start in that order. And I'll hand it off to Andrea.
Wonderful. Well, thanks, Ella. Good morning, good afternoon, everybody. It's really good to be in virtual community today with you all. First off, just appreciation for everybody making some time, and really appreciation for NASHP for continuing to convene these really important spaces, not only for myself and for all of us, but I think, frankly, we're in a really interesting time, at least from my seat and from a housing perspective, where government is playing a little bit of a different role than it historically has, and as it should. And so I think across our respective spaces, whether we are working specifically on housing or whether we're working on the healthcare sector, at the end of the day, for the people that we serve, we know that those services, those cacophony of needs, are really about trying to make sure that we can support everyday folks just trying to get by. And I think it is probably no surprise to any of us. We're in a rough economy right now. Everything from the cost of Cheerios to gasoline to rent prices to mortgage, if you were so lucky to be able to purchase a home if you're a millennial like me and constantly clicking on Zillow to see when prices are going to be not so stubbornly high, it can feel a little bit bleak. And I recognize that, we collectively recognize that. And I think, one of the things I've been reflecting about is this is also such a really interesting time to really reshift and rethink the prism of how government can really show up for people in a way that is not abstract, but in a way that is real and that is a way that is concrete. And so I'm grateful to everybody that is doing the hard work every day, seen and unseen, to really pursue that level of progress. But as Ella mentioned, Andrea Bell, she, her pronouns, I'm the Executive Director of Oregon Housing and Community Services. I'm going to try to get through a lot of content in a short time with hope that we can have some time for a spirited conversation today. So we can advance to the next slide, please. As that's updating, what I'm hoping that our intention for at least my time today that we can go through is, one, is I'm just going to give you just a roundabout overview of Oregon Housing and Community Services Department, which is a housing finance agency. For anybody who has or has not worked with a housing finance agency, and might be wondering, what the heck is a housing finance agency and why are they in this respective conversation? Don't worry, I'm going to cover a little bit of that today. And my hope is that you can, I leave you with at least some one-on-one working information around what does an HFA do and how it can be of partner and of service as we engage in this work together. And then I'm going to give some really concrete examples of how housing finance agencies are working with either our state health agencies and other partners in service to some of these critical outcomes that we are all pursuing. And then my hope is that you can also leave with a couple of really tangible ways of, if you've never spoken with your state housing finance agency, and sort of discerning what might be a reasonable entry point to at least start the conversation, or for many of you who are more advanced and already doing this great work, my hope is that maybe we can hear from you and you can give us some feedback as well as a housing finance agency. As reflected here, just in the most basic form, there are housing finance agencies across the country, all across the country. And we serve as one of a central role in the nation's affordable housing system, really with the focus on delivering financing to make possible really the purchase, the development, and then the rehabilitation of affordable homes and rental apartments for low and middle income households across the country. So if you drive by an area and you see dirt, and over time you see that built up, and if it's affordable or middle income housing, your local housing finance agency may have had something to do with it. But also, just more tactically, why it is so important is, if you are working in the health space or the service delivery space of any kind, generally what I have found is somebody that used to work in direct service. Generally, people's needs are not of one in nature. Generally, there's a cacophony of needs that are happening, meaning if somebody is energy burdened, they're often rent burdened, they are often burdened in other ways. And so while the economy, as I mentioned at the top, is really tough, I am particularly interested in the economy of everyday folks' household. Are they able to pay their bills? Are they able to get by? And with that, our aim is to try to make everyday life better and easier for the people that we serve from a housing perspective. We can advance to the next slide. We can move on one more. I'm going to try to cover content quick here in the ASHP team, so I appreciate you. So as part of our role in the nation's affordable housing system, Oregon Housing and Community Services, our programs typically serve the people of Oregon living at or below area at 80% of the area median income, although some of our programs serve households up to 120% of the area median income. You do not need to be an expert in all of that to know what that means, but just to sort of break that down in terms of who is that in my community, who is that And what does that look like in my neighborhood? You can see here really folks that have fixed income, if folks are on Social Security, if folks who are keeping things every day going for us, that are minimum wage workers, if folks that are working at and staffing fast food, retail, some of the really bedrocks of our community that we rely on. And when those folks aren't there, we feel it in our everyday lives. Those are the people that we serve. What's really interesting and I think really important to keep in mind is, as we have had so many conversations with folks around what does it mean to build affordable housing? What does it mean to build it in a way that is an asset to the community, that can help connect communities where once the building of affordable housing not only left out a whole segment of folks, but it divided a lot of communities as well. I think what's really important for us to really make sure that we contextualize and that is that this is also a lot of folks that are on Medicaid. These are teachers, these are firefighter workers, these are admin assistants, these are everyday folks that we encounter and engage with. So really sort of gone are the days where affordable housing means a certain segment of folks. I think the reality is the economy is pinching a lot of folks. And so our aim is to really not only build in volume in terms of more affordable housing, but making sure that we are doing so in the context of communities, which means we don't want solutions that are only defined by government and by the state. We know a lot and we don't know everything. And so a big piece of that is making sure that the decisions that we make is from a policy perspective, from a programmatic perspective, ultimately the measure of that effectiveness is it working in everyday community? So if you're in very rural Oregon, are the solutions for affordable housing working in the context of your community? And so those are sort of some of the metrics that we are looking at with that. We can advance to the next slide as well. So for Oregon Housing and Community Services, we as an HFA, these are some of the core tenets of what you'll see that most HFAs have as sort of similar characteristics, particularly on the affordable rental housing and on the home ownership side. For the sake of today's conversation, I'm going to focus mainly on partnerships on the affordable rental housing side, but know that it does have a direct tie to some of those services and attributes that are categorized here as housing stabilization. Oregon's Housing Finance Agency, in addition to building and preserving affordable housing and ensuring that we have really solid pathways for home ownership, has a whole division that focuses specifically on homeless services. So we have a number of programs and more recently administered an executive order specifically on homeless services. All of that work is done in partnership with some of our state partners, both on the early learning and education, on the state health side. But really when we talk about the most extreme manifestation of poverty, which is homelessness and unsheltered homelessness, really the root cause of that, it's not the primary, but it is one of the important root causes of that is unaffordability in supply and lack of supply. We've got a mismatch between supply and demand of affordable housing. I'm sure many of you as states are also feeling the pinch between very low vacancy rates as well. One of the central roles that housing finance agencies do is, if you look under the affordable rental housing side, those core programs, that is just a snapshot of supply side resources that we administer. The reason why that is so important is the HFAs are not the only, but one of probably the most significant funders of building affordable housing. At that top, when you see the 9% and 4% low-income housing tax credit, the low-income housing tax credit is one of the most critical engines for building affordable housing. We don't have enough of it. We're waiting for Congress to do something about it. In the meantime, we continue to have work to do. And so as you're thinking about it from a health perspective and from a state perspective, know that many of those programs, they're not just dollars that need to get out the door. Each of them are tied to really important outcomes and attributes. So for example, with each of those funding sources, we put a requirement on certain partnerships. Some of the resources that we'll talk about focus specifically on serving households or serving individuals that are experiencing chronic homelessness. Serving elderly, a lot of folks that are receiving services from other core programs and services, but also that are likely either Medicaid recipients or Medicaid eligible, so which is a really clear and distinct point of intersection. Next slide, please. Thank you. So as we're looking around some very clear partnerships towards outcomes, one of the most important kind of pieces there that I will highlight for you which is not new, is around permanent supportive housing. So as we have, and I know Oregon is not alone in that, as we have looked over the last few years, it has been no surprise that we have experienced an increase in homelessness, an increase in unsheltered homelessness. And even though Oregon's HFA, Housing Finance Agency, and other housing finance agencies, that may not be their core expertise is delivering homeless services, but inherent in the word homelessness is without a home. And being that housing finance agencies are building the breadth of affordable housing across the nation, we saw it as not only necessary, but inherent as a moral imperative for us to making sure that we are building affordable housing and doing so in a way that can harness resources in really specific ways. So for the state of Oregon's permanent supportive housing program, we essentially are funding the capital, and we fund the rental assistance, and then the services are funded through our good partners at our state health authority, so the Oregon Health Authority. That program has been up and running for a few years now. I think as we have continued to look at the outcomes on it, it has continued to yield some of the most significant and important outcomes from a sustainability and housing perspective. The other piece of it, which I know each of you know, is can you imagine delivering services to somebody sleeping outside every day and then thinking that you're going to yield the outcomes? That is not only sort of just bad and uninformed policy, it isn't real from a human perspective, because at the end of the day, we're centering humanity in this work. So we put up capital resources and rental assistance resources. And one of the things that we have found, and I'll be curious if others are sort of similar in this, we actually didn't have a pipeline for capacity for building permanent supportive housing. It was something that was newer for the state of Oregon. So in addition to actually building up the program and resources that are current service level that will be building up over time, we also established a permanent supportive housing institute. So this permanent supportive housing institute essentially brings together the developer, the property manager, the service provider, and in partnership with CSH, they go through this institute. And this is where they get to learn the tactical, practical skills of administering PSH. Not only is this important because it's sort of helping to build the pipeline and capacity of it, but at the end of the day, these are folks that have real projects. So we're not just talking in the abstract and learning, from a school book, if you will, about permanent supportive housing. This is folks with a real project where we are learning about, they get to learn in real time about that. I think it's probably no surprise to anybody here that at the end of the day, part of our shared goal is to make sure that we are supporting people in their tenancy, which means we can't just build it. We need to support people as they're integrating into communities to be long-term successful humans, people, and tenants in there. And so a big piece of that is having a long-term focus on the asset, both on the project itself of making sure that it is integrated into community, that it's an asset to community, and that we are delivering the appropriate individualized services to support folks. Over the last few years, our goal has been to create about 1,300 units of permanent supportive housing. We've exceeded that, and that will be something that we continue to focus on over the next couple of years. We can advance to the next slide here. And then pivoting on to a slightly different partnership, and this is done with our state agency that focuses on early learning. So full disclosure, housing finance agencies, at least Oregon's housing finance agency, early learning and childcare could not be the furthest from our core expertise. But a few years ago, as we were really diving into the data about the realities around upstream investments and where we can sort of set the tone and set the bar in facilitating progress, one of the things that we had found is that over 30 Oregon counties are childcare deserts. So if you can imagine being in a community and not having enough affordable housing, having limited and tough wages, and the not having enough childcare. That is a disruption to everyday life, and these are issues that we can do something about these issues. So in partnership with our early learning, we launched the first CARE program, C-A-R-E, which is an early learning, a program that focuses on building affordable housing with early learning for children ages 0 to 5, integrated into the affordable housing development. And really, this is a requirement for all projects to be intentional about aligning and offering services for families with children 0 to 5 within the context of their community. I don't think it's, I'm sure most of us are familiar with the realities that when we look at and really understand the realities between homelessness today and affordability today, we know that childcare plays a really important role, not only in our economy, but for people to participate and go to school and go to work. And I think we have also seen, and I think have been heartened by the number of times that children and students need to move multiple times throughout the school year just to maintain and keep affordable housing. So it would be unrealistic from our point of view as a society, as a government institution, to ask students to go to school every day, to be well, and in some of your most formidable years of 0 to 5, that you don't have access to affordable housing, or it is in question from month to month. And so this is one of the first really major goals at narrowing that gap. This is done in partnership with a community development financial institution and some of our early learning partners. And so this is work that is undergoing right now, and one of the areas that we hope will continue to expand in that as well. We can advance to the next slide, please. And then just as I'm wrapping up here, just for sort of a visual cue here, in case anybody has never seen what a development actually looks like with co-location of affordable housing with early learning childcare in it. These are some pictures here of one of the developments here, and of course we're looking forward to seeing more of that. And then as we advance to the next slide here, and I'll yield back to the NASHP team and round up my time here. Just a couple of very key points I would leave folks with as they're thinking about partnerships and what that means in the context of your work and what you're trying to get done is, one, if you don't know your HFA, find them. I think that's a really important place to start. The secondary piece is each HFA works on something called a qualified allocation plan. This is sort of a guiding and planning document for low-income housing tax credit resources and how they will be spent. How something is spent is an opportunity to really make important policy decisions and make sure that agencies are teaming up not only in the abstract, but teaming up in resources and services to facilitate those outcomes. If it doesn't happen at the policy level, it's likely not going to just happen on its own, or not to the extent that it could. And then the third thing that I would just say, not that I need to galvanize this group of experts, but really collectively, we are all here because we insist on a better future for our state and for our nation. And in that, there's an inherent mandate to find and make government work. Even when it feels like it can't work. And I know that there are those days where we can really start some really tactical conversations around trying something on for new. So with that, I will yield back for that. I appreciate the time to be here, and I'll take questions when the time is appropriate.
Thank you so much, Andrea, and appreciate you underscoring, leaving us on that note and underscoring the qualified allocation plan as one important resource. I do see that Lisa asked a question in the chat. Is the PSH program project-based?
It is project-based.
Wonderful, thank you.
Can we clarify real quickly, by project-based, we mean single site with services on site? Is that what we're...
That's correct. And then the referrals come through coordinated entry. So locally, the referrals come through coordinated entry, and then each of those partners work, but it is services are on site for each of the households residing at that particular location.
Thank you. Are there any other clarifying burning questions for Andrea before we move on? Feel free to speak up. All right. Well, then I think we can move on to David.
Good morning or good afternoon, depending where you are. My name is David Bridge. I am the Special Needs Administrator for the Arizona Department of Housing, but I'm here today in my role with the Arizona Balance of State Continuum of Care to talk a little bit about, give some background on the HUD Continuum of Care programs. Just looking real quickly at the map on the right that we included. A continuum of care is basically a geographic area that, under HUD rules, comes together to coordinate the McKinney-Vento funding for those communities that have opted into that continuum of care. And so for Arizona, we have 3 continuums of care. We have one for Maricopa, which is Phoenix, you're most familiar with. We have another one for Tucson and the Pima County. And then everything else in Arizona, the other 13 counties, fall under what we call the Balance of State Continuum of Cares. And a lot of states are set up this way where, the major urban areas may have 1 or 2 continuums of care based on their size or by county, depending, what's the largest unit of government or the controlling unit of government. And then a lot of states also have this balance of state, they call it, where the other smaller counties fit in or all coordinate together. And we'll talk a little about the challenges some of those present. Next slide. So basically 3 things we wanted to go today, just kind of like Andrea's presentation. First, we just wanted to give some background on what the COC is, about the Hearth Act requirements around the continuum of care, a discussion around funding versus system requirements of the continuum of care, which is critical. Second, we'll talk about some of the challenges that the continuum structure can pose in terms of collaboration or addressing some of these issues. And then finally, we'll talk about some of the opportunities that it presents that make it easy to work, that could work on bringing communities together and coming up with solutions to address homelessness. Next slide, please. So very quickly, again, McKinney-Vento funding is the primary HUD homeless program. There's 2 components to it. There's the continuum of care funding, which we'll talk about today, and then there's the emergency solutions grants that fall under it. Basically, this is the McKinney-Vento has been there for a while, but in 2009 they reorganized it under the Hearth Act. You can look this up at 24 CFR 578 is the overall legislation. But basically, this is the majority of homeless funding for that the federal government puts out through HUD. Directly for homelessness. And so basically under the CFRs, there's 6 things that a continuum of care has to do. Again, a continuum of care is a geographic area that has been identified by HUD that is supposed to do these, you're supposed to do these 5 or 6 things for that community. So whether it's a city or a balance of state or a county, these are the requirements that HUD requires to get the federal funding through McKinney-Vento or for the continuum of care funding. So the first is you have to create and establish a continuum of care board. And so we have a Balance of State Governance Advisory Board. So that's a group of individuals that comes together. We'll talk a little about who makes that board up, but they're responsible for making sure that these other things are done within that community so that HUD can fund that community and provide the COC funding for that community. The big piece, and that most people, when they think about the continuum care of, is they think about the annual NOFO, and this is an actual application we have to put into HUD every year. It's a competitive process. The board has to identify a collaborative applicant or an agency or an entity to put in that application to HUD. And basically what can be funded with continuum of care funding is permanent supportive housing. It can provide rental assistance, like vouchers. It can be used as leasing dollars where you lock down blocks of units for members or for people experiencing homelessness. It'll fund operations of leasing programs and some other of the costs of operating a housing program. It'll pay for some limited supportive services. And traditionally, well, the statute allows for construction and acquisition, but HUD hasn't allowed that as an activity within the NOFO for quite some time. It also funds rapid rehousing, so temporary vouchers or to help people move towards stability in a shorter time. Again, they'll provide for the rental assistance and services related to those programs. It will fund some transitional programs with rapid rehousing. So if you're going to do transitional like bridge shelters, you have to have a rapid rehousing component to move people out of the transitional program. And then finally, they do provide some money for administration of the grants. They have what's called COC planning money, which is for coordination and doing some of the other things we're going to talk about in a minute. And they'll also allow you to fund some of your HMIS or your homeless management information system we'll talk about. Second thing that once you have the funding, the continuum of care is responsible for making sure setting and monitoring the performance and the homeless outcomes for those providers that you're funding. That also includes overseeing and coordinating with the ESG programs or the Emergency Solutions Grants programs, which are often run through other state agencies or other entities or governmental entities. UFA is a Unified Funding Authority. That's a unique type of COC where the funding is directly managed by the continuum of care as opposed to with the participants. We can talk about a little bit because there are starting to be more of these UFAs popping up. The fourth thing we're responsible for is all the HUD reporting. And you guys probably see these reports, you know, when they're, because a lot of them are published annually as part of HUD's reporting on homelessness. So the big one is the point in time count and the housing inventory count we do every year. That's kind of the number that everybody listens to. When you see those numbers that homelessness is up 15% in a community or down, or, you know, nationally it's up to, you know, 500,000. That's usually coming from the point in time counts that we're required to coordinate. We're also required to do a gaps analysis on what's missing in our local systems and our continuums. We do a report called the Longitudinal Statistical Analysis, which drives a lot of the annual homeless analysis reports, the AHAR, that HUD puts out. We also have system performance measures we have to put out, and we have a consolidated plan that we contribute information to. The last bullet here is the most important, and I think this is where it really ties to those of you in the healthcare community or maybe other systems of care outside the homeless system. So HUD has this language in the Hearth Act as one of our requirements as the COC or the continuum of care is to coordinate a housing and service system that meets the needs of homeless individuals, including youth and families, at a minimum that encompasses outreach, shelter, housing, supportive services, and prevention strategies. One of the things I'd point out real quickly there is that if you look above of what's funded by the continuum of care, it's permanent housing, rapid rehousing, transitional programs. But if you look at what we're required to coordinate under the continuum of care, we're required to bring in all those other wraparound services, outreach, emergency shelters, and other types of transitional shelters, other supportive services, and then prevention. Again, HUD doesn't fund those through the continuum of care, but there's an expectation that we're coordinating with those systems. And some of the systems that HUD has required that we create as part of the continuum of care to support that coordination is coordinated entry. You heard Andrea talk about taking referrals from coordinated entry. We're required to have a homeless management information system for our continuum, and then we are required to coordinate with the domestic violence system. Next slide. So real quickly, the way I like to think about it is big C and little c. So again, under little c is basically the minimum things that we have to do as a continuum of care to make sure that that continuum of care money comes into the state. Again, putting the application together, you know, making sure we're evaluating programs and things like that. But the real expectation of what the continuum is supposed to do is to be the coordination point for that continuum of care, to bring all the different resources together. And what you see here, and this is from the Hearth Act, when we're talking about who's supposed to be participating in the continuum of care, it's the representatives from relevant organizations within a geographic area. And so this list that you see here, in the large blue big C continuum, are all the other groups that HUD expects us to be working with on our boards and that we're coordinating resources around. So law enforcement, police departments have an impact on homelessness. You'll see physical and behavioral health providers. That would include like our Medicaid programs, hospitals, the faith-based network, formerly homeless persons, people with lived experience, affordable housing developers, and groups like Andrea's that are developing the housing. Again, HUD doesn't pay for the housing through the continuum of care, but we're expected to, you know, develop the housing that our members need. School districts, housing authorities, again, all these groups are supposed to be coordinated through the continuum of care on the big C. Next slide. And so the way I like to think of it is kind of like the duties of what we have to do. So again, little c, we have to have our local board. We have to make this annual application for funding each year. We have to set standards and evaluate our funded projects that are COC funded. We have to coordinate, and we have to have this coordinated entry system. We have to prioritize people and our resources based on the criteria that HUD has kind of established. We have to have this HMIS system, and then we have to work with the domestic violence system, the VAW. We have to make sure VAWA is being applied within our projects. On the big C level, and again, where it really applies to all of us here, is all these other things. So again, when we talk about large coordination, our board, we have to have membership from all those other groups. We have to have, representatives from our healthcare system. We have to have representatives from, our emergency shelter and faith-based system. All those have to be kind of incorporated into this board governance and to help make decisions on how we're using our COC funds. Our COC scoring is based on system coordination. So in that application we have to do every year, yes, they look at our COC outcomes. They want to know, how many people got housed and those types of things. But more importantly, probably half the points and questions come from system issues. How are we working with the school districts? How are we working with healthcare? How are we working with outreach? How are we working with the Veterans Administration? How are we working with the DV providers? Again, even though most of those programs aren't funded through HUD, through the continuum of care, we're still getting scored and evaluated as a continuum on how well we're bringing all those partners and stakeholders together. Our reporting, again, is system level a lot of times. Yes, we have to say how each of our projects is doing, but the HIC and the PIT, the housing inventory count and the point in time count are counts of everybody in the community, whether they're being served in a COC program or not. That number that we give every year is really the number for that community, for that entire continuum, not just the COC funded programs. Same thing, we have what's called system performance measures that measure how many people go into housing, how many new people hit the system, what recidivism looks like in the system. And again, this is not limited just to continuum of care providers. This is limited to all the resources in the community that are participating in the homeless system. So we're required, though, even though we're not funding these entities, we're required to reach out to our faith-based partners. We're required to reach out to our emergency solutions grants partners and our systems that are funded through other resources. Coordinated entry is required of COC providers. That's where they're supposed to get their referrals. Same thing with ESG is supposed to, emergency solutions grants are supposed to participate in coordinated entry. But we're not, coordinated entry can include any providers that want to participate in the system, and other systems have required their agencies to participate in the continuum of care coordinated entry system. And we'll talk about some of the challenges that presents. Same thing with HMIS. Technically, HMIS is just COC providers, but HMIS now probably includes, at least in our continuum, over half of our providers in HMIS now are not COC funded programs. They're VA programs and faith-based programs and all the other stakeholders who are providing housing in our system. We're required to work with DV providers, we'll talk a little bit about, and then again, we're required to align with these other federal and local programs. So the PATH program through SAMHSA, the VA, the Veterans Administration, the DV programs, Medicaid and Medicare programs, again, as well as housing and shelter programs. Next slide. Go real quickly these last two. So some of the challenges that are presented through the continuum of care that you may have already experienced if you've tried to work the continuum of care is the first is the HARP Act defines homelessness very specifically for the purposes of a COC. The target that they really focus on is literal homelessness, people who are actually experiencing homelessness. So generally that doesn't include people couch surfing. If people are coming out of institutional settings like healthcare settings or hospital settings, there's a limit. They have to be in that setting less than 90 days and they have to be homeless before they go into the system. Some of those things cause problems when we're trying to coordinate with a homeless system that has a patient that they're trying to maybe discharge from a hospital or an inmate that we're trying to discharge from a jail who's experiencing homelessness but may not meet that literal definition that triggers, the eligibility for some of the homeless programs, that's the COC funds. There's also a term chronic homelessness that you'll see. Andrea referred to it as well. Again, that's a HUD term of trying to identify who the kind of high acuity members are within the homeless population. HUD bases it on length of stay and on having a disabling condition, but that doesn't necessarily tie, like for instance, when we work with healthcare, to those individuals who may be determined SMI in the behavioral health system. It may not tie to high cost, high needs populations. It may not tie to high recidivism that maybe some other systems of care that we're expected to coordinate with use to identify their high level members. The intervention types, again, we only fund permanent housing. And again, there's a need for these other types of services like transitional, bridge housing, emergency. So that can be a barrier. The standard reporting can be hard for agencies that aren't, just like a homeless program trying to work in the Medicaid system has a hard time trying to take on those administrative reporting duties. It can be hard the other way, trying to do HUD duties if you're not a traditional HUD reporter. Again, we don't fund all interventions in the COC, so it's a lot of coordination with these other services. Housing first, we can talk about. One thing that I always make clear is that when we talk about permanent supportive housing and housing is only effective as the services that we wrap around people. And again, the COC funds primarily housing, the units and things that we need, which are absolutely critical. But if you don't wrap services around people, that housing can be very ineffective. And so the housing first piece, and again, there's a lot of political heat around housing first right now. We can talk a little about that. But that can be a barrier for some people participating. Coordinated entry prioritization, again, we're prioritizing people based on the HUD definitions a lot of times, and that may not align with who the high priority people are in other systems we're coordinating with. HMIS is great, and to the degree that we have people participating, but there's some caveats. It's self-reported data, so we don't necessarily, if somebody says they're mentally ill, we take and check that box, but that doesn't mean they necessarily qualify for those services or have been, approved for those services, say in the Medicaid system or in the behavioral health system. Again, it's limited to who's participating. So if it's only COC providers, we don't have a great look at the whole community. So, trying to get more people into HMIS. And then the standard reporting can be a little difficult for some people. We've already talked about system coordination. And then one thing I just want to make sure is I think there's this myth that we have a lot of housing, because HUD will say, SAMHSA, their latest thing on the 1115 waiver said, work with your mainstream partners for the housing piece. We're going to fund these waivers, but we're not necessarily going to fund permanent supportive housing. We expect you to work with PHAs and the continuum of care. Right now, all the programs I'm aware of have huge wait lists. In the balance of state, we have a wait list of over 2,000 people. That's in addition to the 1,500 or the 3,000 or 4,000 people on the Maricopa wait list. And on the, Tucson in our state has another 800 or 900 people on their wait list. So this lack of resource. So just because we have these resources available doesn't mean they're easy to get to, that they're immediately accessible, that there's not wait lists and a lot of other processes involved. So that can be a real barrier. Final slide. Sorry, I'm a little bit over. I'll go real fast on this one. But I think some of the opportunities that we have that I would really encourage, especially those of you in the healthcare communities, to reach out on. The first is the continuum of care funding. One thing every year we're required as part of our annual application for funding for our projects is we have to show 20% match or 25% match, very similar to what the Medicaid system has to do. And that match can come from other sources. As I said, HUD loves paying for the housing vouchers, but if you can bring match from the Medicaid system in the form of supportive services, case management, treatment, child care, all those things that we know people need to be successful, partnering with a housing project is a great way for us to meet that match on the COC side while linking, to the special populations that need services and better serve those populations. The second thing is every year in the NOFO, HUD sets a list of policy priorities and awards bonus projects that meet those policy priorities. And right now, at least we're waiting for the new NOFO to come out, but traditionally some areas that are really good for the group here today, one, domestic violence partners. If you already work, there's bonus money for domestic violence programs. More importantly, right now, we get bonus points on our applications if we can show that we have projects, new housing projects, and voucher projects that align with Medicaid or bring healthcare coordination. So again, those programs that bring dollars from the healthcare system for services or to support some of the other housing costs related to these projects. So there's a great opportunity to kind of create new projects with this integration of healthcare and continuum of care homeless funds. Same thing with public housing authorities. Right now, there's incentive points in our application if we're working with housing authorities or other mainstream housing programs to do the COC will do 10 vouchers for this target population. The PHA is going to contribute, additional units, and we get bonus points. And those bonus points become critical because if you get bonus points, you can actually see an increase in your COC award. Coordinated entry prioritization is a huge opportunity. Again, HUD does allow us to use other criteria for identifying high cost, high needs, or chronic populations. As I said, the chronic definition can be limiting to like a healthcare system. But again, right now there's a lot of work being done to try to figure out how do we find out who are the really high acuity people across systems, not just in the homeless system, not just in the behavioral health system, but across systems. The Medicaid waivers are a huge opportunity, obviously, to bring some of these services to bear. Data sharing, a lot of states right now, including us, are working on data sharing projects to better understand, again, these issues around who's in which population. We know that, there's behavioral health issues and substance abuse in the homeless population. Again, it's self-reported on our side. So how do we confirm that information to make sure that it's actionable on the behavioral health side or on the Medicaid side, bring resources to these individuals. And then finally, there's a lot of work, at least in our community right now, around shared service standards. So, what should a shelter provide at minimum? What should permanent supportive housing, supportive services look like? And if they're going to be funded by by Medicaid, Access is our local Medicaid program, but if they're funded by Medicaid, should some of those standards also align with the standards we set on the homeless side so that we have, no matter what shelter you go to or what housing program you're in, no matter who funds it, there's a base level of expectations and services attached to that. Anyway, that's a quick rundown. I can go into depth. Sorry, I have limited time. But like I said, if you have any questions, I'd be more than willing to discuss or talk about.
Thank you, David. That was so helpful. I will hand it over to Dominic.
Thank you.
Thank you, Ella. Thank you also, Andrea and David. I took a lot of notes during your presentations. It was really great to hear from you. I think a lot of this work is kind of, nobody's piece of the pie is big enough. And so we kind of have to collaborate together to try to find solutions in our communities. And so I just really appreciate learning. If you could go to the next slide, please. I have a lot of slides, but I'm not going to go through all of them in any detail, but I want the information to be available as a resource after this presentation. I'm going to kind of start with some basics on PHAs, and then I'm going to talk a little bit about Minneapolis, and then a little bit about St. Paul after that. My career actually started in the city attorney's office in St. Paul, so I'm an attorney by trade, but I started with the Public Housing Agency in St. Paul thereafter, and I managed and directed the voucher program for about 10 years there before I came here about a year ago. So you'll see some of my examples towards the end are a little bit more about St. Paul because that's where I had a little bit more formative work, working kind of across the sectors. But here in Minneapolis, we also do a lot of really great things. I just know a little bit less about them. So I'm going to start by talking a little bit about Minneapolis. And then St. Paul. Next slide, please. So there's a lot of information here. I just wanted to kind of do some level setting around like what public housing authorities are charged to do. So they've been around for a long time, and then the Section 8 vouchers maybe less. And then you'll see that each public housing authority has a unique charge because we all make our own mission. With the help of our boards and our local communities. But kind of the things in common are that they administer usually some form of public housing. So that's housing that we own and administer. And then most housing authorities also have Section 8 or housing choice voucher programs, which are programs with private landlords in that respective jurisdiction. Public housing itself is really dramatically underfunded, and it continues to be underfunded. And that usually is because the capital funds that we get to upkeep our own buildings are far less than we need. And so we have to move funds around to actually kind of make it work. And over years of disinvestment, we kind of have much less to work with. And of course, the needs of our community are not decreasing. The Housing Choice Voucher Program has fared a little bit better because they have bipartisan support, typically because of that private rental market involvement. One other thing that's very much in common is that we are really serving families, individuals with very low and extremely low income. So these are really your families, individuals with the most needs. We uniquely provide that deep subsidy in our funding environment. And a lot of times our task is kind of how to leverage that subsidy with effective supports. Kind of with the exception of the emergency housing voucher program, which we'll talk about later, we are not funded to meet supportive service needs for the residents that we're serving. And we still find the money to do that because we know how important it is to really effectively serve residents where they're at. But we are consistently looking for partners in funding in this area in particular, because this is how we can kind of ensure successful tenancies for both our residents and our voucher program participants. But beyond that, each agency is really unique, and there's a lot of discretion to meet our community needs. We're mission oriented, and we have our administrative plans that guide a lot of our work, and our Board of Commissioners, locally appointed, approves all of those things. Next slide, please. So I want to just say a little bit about moving to work. It's a special designation. You see the map on the right with the authorities that have this designation. And essentially, we get to kind of waive some HUD regulations in the interest of community needs. And there are particular charges that we have to meet when we're doing that. But it really does give us, first, solutions that are outside of the traditional voucher and public housing programs. But it also allows us to move money between the programs, because all of these programs are funded in silos. And to kind of break down those funding silos allows us to really meet resident and community needs where they are. And so we've done a lot of that here in Minneapolis, and I'll share a few of those examples later. But I thought this would be really relevant for those of you across the country, because when you're working with the Moving to Work agency, they typically have more latitude to find solutions to community needs, whereas traditional housing programs and housing authorities have a little bit more emphasized guardrails, I would say. Next slide. So this is just a little bit of an overview on Minneapolis and kind of an outline of what I plan to cover on the left. What I wanted to note in our mission statement, and this is also true for St. Paul, who has a similar mission statement, is that we rely on our partners to complete our mission. When we talk about the well-being of the individuals, families, and communities we serve, we are constantly looking for partners, and this is how we get our work done. We recognize we can't do any of this alone. Next slide. So I also wanted to share this. I'm not going to go through all this content. It's a ton there. But in Minneapolis, our program's a little bit unique in that in our public housing portfolio, we have about 42 buildings that serve about 5,000 individuals. And the next slide, you'll see that they're predominantly elderly and disabled individuals. Then in our deeply affordable family housing, we have a small portfolio of tax credit properties that are usually serving larger families because they're scattered homes, single family and duplexes throughout the city. And then on the right there, you see our Housing Choice Voucher Program. The voucher was really made for partnerships, in my opinion. And so I'll go to some more examples there, but we kind of serve the whole spectrum in our Housing Choice Voucher Program. Next slide, please. And here are those demographics just supporting exactly what I just said. I thought I'd leave this there for anybody who wanted to digest it in more detail after. Next slide. So I'm going to talk about a few examples in our public housing portfolio of collaboration, and then I'll go into the Housing Choice Voucher Program, and I'll talk about the Housing Choice Voucher Section 8 program from Minneapolis, that perspective, and then also from St. Paul's perspective. So we have in many of our high rises, because we serve so many elderly individuals, and our high rises are almost all one-bedroom units or efficiencies. We have assisted living centers that are in some of our high rises. These started out of kind of organic partnerships where we said we would give partners the space to run a program and we would not charge any rent for that space. However, as you can imagine, as the reimbursement rates, at least in our state, Minnesota, have not increased, and we have a very competitive labor force here in the metro, those programs are failing because the gaps are too great to meet those needs. And so we used to have 8, and now we have 5. And we really try to hold on to them. And we've even been approached by some to kind of fill those funding gaps, but that's been a challenge. Next slide, please. The Volunteers of America is where we obtain kind of our core supportive service for all of our residents and disabled residents in the high rises and in our family units. And there they offer congregate dining, nutritional health education, and some homemaker chore service referrals. That contract continues to their ability to serve the residents has been decreasing while the costs to the agency have been increasing. And this is something we completely understand from the outside, particularly since the pandemic, when we're trying to kind of find out where we can most effectively serve our residents. But it continues to be a challenge, essentially more gaps there. We have in Minnesota, Minnesota Medical Assistance Benefit that's for people searching for housing and people in housing, and it's called their Housing Stabilization Services, and it's a Medicaid waiver program. I don't understand all the details about it, but we try to enroll our participants in this program, our residents, but it hasn't worked very well because we're going to be providing the services to them either way. And so to have them go through the relatively arduous process of self-enrolling, which requires a few back and forths with our Department of DHS here in the state, it's been really slow going. But it was one way we were trying to increase the revenue for us to provide more services to our residents in the places where they live. Next slide. And then the last high-rise example that I wanted to share was kind of one of our newer ones. This is resident-driven, and it's really a great example, I think, of cross-sector partnerships. We formed it in 2020 with some grant funding in the first place, and they have regular community meetings, and what they're trying to do, first and foremost, is hear from the residents on where they need help. The idea is that both the care providers, the care funders, and the PHA and the residents all win if we can reduce obstacles in care for our residents who need it. And so our most recent set of priorities, they're reevaluated every couple of years, is in behavioral health. And the leadership meets quarterly, and then there are subcommittee meetings more frequently. And those are, again, driven by the residents with a little bit of staff support from the agency. But there's a lot of interest from our partners on this work. One recent grant funds essentially substance abuse recovery clinics at both the north side of Minneapolis and at the south side. And they're monthly meetings, I believe. And it's been really effective in answering resident needs and finding resident solutions to what they say that their problems are. And so we really like this model. More to come here. Next slide. So I just wanted to give a little bit of background on the two public housing agencies I'll draw from here. So in Minneapolis, we have about 6,300 Section 8 vouchers. In St. Paul, we have about 5,200. And you see that in Minneapolis, we have Moving to Work Authority, which is kind of taking the guardrails off of some of the solutions we can find. In St. Paul, we did have those guardrails. And so we had to work through our policy and a lot of HUD regulations to find solutions. So I wanted to give that background so you can kind of see when you're working with your local public housing agencies where there might be more ability and where some of these solutions might work in either case. The one thing I do want to touch on, the Stable Home, Stable Schools program in the Minneapolis column, that's a partnership with our schools and our county, and they use some local homeless prevention aid. And this it was started just before the pandemic. And then through the pandemic, it evolved. The needs of our residents and our participants certainly evolved in that time. And so this is just a really good example of our using our Moving to Work Authority to meet a community need. And we now serve all schools in Minneapolis and ensuring that families are housed, stably housed, so that their children can meaningfully participate in school. We're very proud of that program. Next slide, please. So again, just some basics. You see our tenant-based vouchers are about 4,500 units. And that's just the standard voucher program where they receive a voucher and then they find a unit on the rental market. And there are some special program allocations I'll talk about in a little bit. But we did use our Moving to Work Authority to create rental reform, which we waived a regulation to allow our residents and participants to find more homes to live in. So we kind of increased the affordability threshold at the outset to increase that universe of affordable units for our families. Our project-based voucher program, we have a lot of units there, over 1,700. And this is where the subsidy is paired with the unit. And then that can be leveraged by the developer to create more housing solutions for that particular project. So usually it results in more supportive services for that community because they can leverage that long-term essentially guarantee with the project-based voucher. We do have referrals from the continuum of care. In St. Paul, that was a requirement for supportive services. In Minneapolis, it's more of an option. And we used our moving to work authority to essentially remove the cap that the agency has on how many vouchers we can project base. The idea being that this is a resource that can really be effectively leveraged to create more services in these projects. And so we see that, and we're trying to do more of that. Next slide, please. Now, before I move on into the St. Paul examples, I just wanted to list a few different areas. And it's interesting, David and Andrea and I did not talk first, but some of these examples go to some of the things that they were talking about as well. So we're looking at expanding with our voucher program and with our public housing program, as I stated, our collaboration with this Medicaid implementation on the housing stabilization services. It feels like it should be a panacea for all of our residents who are almost always going to qualify for this resource. But there are so many barriers in enrollment that we're still trying to figure out effective ways to unlock this. And so I think it's just really important for me to note that as an area of opportunity because we continue to try to break down some of those barriers. We've also recently learned, maybe about a year ago, about the community choice behavioral health clinics. And we have a few of those located in our area. And this is, again, another opportunity to break down barriers for our residents who need care referral, more services, just kind of how am I going to find a doctor, those kinds of things. And so we're really trying to figure out how to best amplify that message to our residents and our voucher participants. We've recently been learning a little bit about what other agencies do, particularly moving to work authorities, like partnering with an early childhood focus, recognizing that impact lasts long through life. And so we're looking at both housing choice vouchers, pairing our voucher with supportive services with others who could then kind of bring in that early childhood focus so we can make really effective solutions there. And always trying to improve on service connections, both for our public housing residents and HCV participants. It's a little bit of a different model working with the residents that live in our buildings because they have a strong investment to improve these things. That's why we see the High Rise Health Alliance. With our HCV participants, I think of our role more as a communicator, reminding them what resources are out there for them. Next slide, please. I'm not going to talk about this, except for to say that on David's point, both here in Minneapolis and in St. Paul, we did take more involvement with our COCs right around like maybe a year or two before the pandemic. And we knew about that bonus that was given to the COCs, but it was also kind of a win-win for us because we could learn from providers on how to more effectively serve our families and our individual clients. And so it's been really educational for us, and we continue to look for ways to collaborate more effectively in this system. Next slide, please. So these are a few voucher types. And I wanted to put this slide up to illustrate that HUD is really, when they're awarding new resources to public housing authorities, they're usually creating specialized programs that require us to form partnerships with others. And like I said, this isn't a bad thing. It's been very effective in reaching some populations that have very high needs. So our VASH program are our veteran vouchers, and these are for supportive service, these are for homeless veterans, and we partner with our federal VA partner here in the Twin Cities. And that is really true housing first. They come in with strong supportive services, and we've actually worked with them to also, in some cases, make these project-based resources. We also have our family unification vouchers where we partner with our local child welfare agency and also with our continuum of care in referring families and youth who need assistance in order to remain effectively housed. We have our mainstream voucher program that I'll talk about in a little bit more detail, as well as our emergency housing voucher program. But those are more programs that kind of tailor service needs to specific populations. And so PHAs are essentially charged with working across sector to meet to find effective solutions for these folks. Next slide, please. So I only have a couple slides left. And this one I want to just say a little bit about. This is when I was in St. Paul, we formulated a program with our mainstream vouchers. And it was really born because I just recently become involved in our continuum of care. And we had a NOFA for these vouchers. And it said, we really would like you to tailor these for homeless individuals and families. And I had been in meetings at the COC, and I thought, well, this is really a great idea to just run past the COC to see where there might be interest in partnering on something like this. Maybe we give a voucher, and then they agree to provide services, and then they have vouchers to give to their clients on a referral basis. I really kind of was surprised at the amount of interest from our continuum of care when creating that program. We did create an MOU to memorialize the arrangement, and we pulled language right from the NOFA. And then we did ask for an additional commitment that they provide services for 1 year or longer to ensure that that voucher was really an effective resource for that family. And we weren't just creating a problem or a barrier. And then in our own policy, we created a preference for this process. And then we advertised it on our waiting list. And so essentially we dotted our I's and crossed our T's as a non-MTW program to really work with our continuum of care and find solutions for families and individuals who needed the resource. Next slide, please. So the emergency housing vouchers, the numbers I have here come from St. Paul. The model is almost identical with Minneapolis. HUD created this program during the pandemic as part of the CARES Act, American Rescue Plan. And we had to very quickly, about a month, I think, we had to partner with our COC to create a model and create prioritization and create effective services that would meet the needs of essentially those families, individuals, and their families who most need it. You can imagine that as we're all learning how to do things virtually, this is kind of a heavy lift, but we did get it done. And the models that we came up with look very different in Minneapolis and St. Paul, but it really was a good example of how we could effectively use resources across sector, and nobody had to be an island. We could break down some silos. The only other thing I'll say that's noteworthy here is that this is really the first time that HUD provided funds specifically for supportive services on a per household basis. And so we welcomed that resource. So you could tell as we were going, HUD did continue to refine the rules around those expenses. Next slide. This is the last slide. So I think the main tip I have when engaging your public housing authority or agency is to really understand, make sure you know their mission going into the conversation, and maybe ask the question, where can we help you meet your agency's needs? Where are your gaps right now? Because I was really surprised, and I continue to be surprised at kind of where there's a lot of mission alignment already. And there's some cases where more resources are not needed, but it's really just getting on the same page with a system and a process that might work. And so we continue to always seek ways to do this. And the COC has been a great way for us to do that. And that's why I note here to check in with your local continuum of care. There's one in every area of the country. And at least if any of the two that I've been a part of are any example, they're very hungry for input and they're very hungry for feedback. So I encourage that if you're looking for any more partnership and collaboration opportunities. Thank you for the time. Sorry I went over.